Thanks very much, Mark, and thanks everyone for coming along this evening. So my name is Karen Lamb, and I'm a member of the Biostatistics and Bioinformatics section. So this is our first webinar of the year, and we've got a series of webinars coming up that I'll tell you a bit more in a second. But before I begin, I just wanted to acknowledge the traditional owners of the land in which we're meeting today. So for me in Melbourne, that's the Wurundjeri people, and pay my respects to their elders, past, present, and emerging. So look, I'm ecstatic today to have Katrien Groenhof joining us to speak about the work she's been doing using routinely collected data in the Netherlands to answer important health questions. Now, I was really fortunate to hear Katrien speak last year at the Australasian Epidemiological Association, and I just thought it was such an interesting topic that she was covering, and something that was really relevant to many of us biostatisticians in Australia that are trying to kind of get our hands on this routine administrative data we have here to be able to understand a little bit more about what's going on in the health system. And if any of you here have tried to make use of that data yourself, you'll understand that we face quite a lot of challenges here and are often quite restricted in what we do. So Katrien has taken some time out of our busy schedule as a resident in obstetrics and gynecology today to talk to us about her work in epidemiology. And as I mentioned, her PhD was focusing on making the use of this routinely collected data, and particularly looking at cardiovascular risk management and what can be done with health data in that space. Now, as Mark mentioned, I'm going to restrict all questions till the end, but if you do have questions as you go through, please feel free to enter them in the chat box, and we'll keep an eye on those. Obviously, if you're having any technical issues, please let us know, and Mark will try and help resolve those. And finally, just before I hand over to Katrien, the other thing I meant to mention, as Mark said, we're going to have these breakout rooms at the end. So after the questions, if anyone wants to hang out and network with other people attending the webinar today, please feel free to stay along. We're going to split up into little groups. And Katrien and I will jump into these groups. And if you've got any questions you want to ask her directly, or anything you want to talk to me about with regards to ideas for the biostatistics section, please feel free to chat to us then. And finally, before I hand over to Katrien, I just want to make a little plug for our next webinar, which is going to be held on Friday the 19th of June at 12 o'clock Australian Eastern Standard Time. And we're really excited to have Elasma Melanzi, who's going to be talking to us about microbiome analysis through a biostatistics lens. So I'll put a link to that talk in the chat window just now. So if anyone wants to register for that Zoom webinar, please feel free to sign up. So without further ado, that's enough chat from me. Katrien, over to you.
Well, thank you very much, Karen, for the introduction and foremost for the invitation. I was very happy to meet you all last year in Brisbane, and well, even more happy that there's a sequel to this adventure, my little Australian adventure. Although I'm not physically there, in my time zone, I would say good morning. To you, I say good evening. But I do like to start my presentation by acknowledging your traditional owners and on the land you're all today, and pay my respects to elders past, present, and emerging. With that being said, I'd like to start taking you to the why, because I'm going to give you a bit of an overview today. And starting with the why is introducing the impossible task to you today. And that is that actually in medical care, medical science, we have a split. In science, we are working towards finding the most valid answers to question we have, focusing on validity, generalizability, reproducibility, but we're also facing the problem of trial duration and trial costs in these, well, classical randomized controlled trials in cohorts. And then on the other hand, we have care, and there we have our care experience, but we have this problem with our aging population because care tends to get better and better, so people grow old, who have multiple diseases that are more chronic. And we ask ourselves that we want to provide risk-guided care, so only giving the treatments to those at highest risk, together with all our colleagues, and that we can actually pay for it, so it's value-based. And this is the impossible task of a clinician and scientist that have to work together in this world. But there's actually a science to care gap, but also an unexploited potential in care and care data. And this is what sparkled the interest in what we call the learning healthcare system, which is, as you can see, a cyclic approach of getting routine care data, or as you might call it, administrative data, using data analytics to translate these data into actually actionable insights. So not only zeros and ones, but really something we can act upon in clinics. What I will do today is highlight these steps using examples from cardiovascular risk management. Why? Well, first of all, I was appointed in the Department of Cardiovascular Epidemiology, but second of all, it's also a very good case study, because cardiovascular diseases are these diseases I just talked about, who are chronic, multimorbid, that are affecting a lot of people, both young and old. So they make a good case study to explore this learning healthcare system with. Before I really head off, I would say maybe reading the introduction I wrote for you, which was sent around by the SSA, you think I'll give you a roadmap how to do this. In reality, well, Karen also just said this, that doing this kind of research and science is complex, and you will not have a to B road, but more like the downside. And the good thing is that in these corners and in these difficult paths, you find nice views, and for me, this is actually the fun stuff. So probably if I explain you more about examples, you will have this project of your own you think of, and save these for the breakout room, because I do think that this is just examples and we have to continue to learn together. That's also why we decided to try out the breakout rooms with you. So let's get from A somewhere to B together. And the first step is there, using routine care data. Originally, if you look into science, you want to have high quality input data, because if you put low quality data into your models, you'll get low quality output. Or as the picture also says, garbage in is garbage out. And originally, scientists thought you may not use data that is not collected for the purpose you're analyzing it for. And this is especially the case with routine care data, because it's collected for care purposes, not per se for science. This does not mean that it's not suitable to analyze for your question. And that is where my point in choosing routine care data to answer your question with is that whether the quality of the data is good enough to answer your question is about the ability of the data to answer your question. Now it gets a bit epidemiological, that every question has data demands. This is also in classic research. You have your domain, your determinant, your outcomes, whether it's observational or therapeutic, census or sampling. So these theoretical design items, you also have to keep in mind when you're selecting your data source, if you're using routine care data. So we're trying to answer the question, is the data you're about to use for your question fit for that purpose? I'd start with the first, and here it gets a bit theoretical again, but I'd like you to imagine how data is generated. Because if you're talking routine care data, it is a digital trace that is being made somewhere in the process of care. And I just called it a feature here because it's not per se an event, it's not per se a symptom, it's any variable you want to include in your analysis that is relevant to your question. And whether it can occur in your data source can be dependent on the patient, healthcare professional, or the care organization. I will detail that because, for instance, in the patient, first of all, the patient has to acknowledge that a symptom is relevant and has to seek care for it. So if you're investigating stigmatic disease or patients that tend to avoid care, you might have an issue here that the feature does not occur in the data source because the patients did not visit healthcare yet, does not have the interaction yet. So we need to find a data source where we think that that feature will occur. And second of all, the healthcare professional has to actually make the digital trace in the electronic health record, for instance, or in the registration for the municipality. A very easy example is that if you look for blood pressure, I would not go for the orthopedics healthcare records, but for the vascular medicine. It's just which professional thinks which features are relevant to their disease trajectories. And last of all, care organization is also very important, because if you have these gatekeeper systems, such we have in the Netherlands, that some care is being provided in primary care and others is being provided in secondary or even the university medicine centers. So really think of how your care system is organized to see which data you could best use. And I put the nota bene below it because you really have to discuss it with those who make the digital trace. I've had some fun encounters with Karen and also other researchers that have a bioinformatics background, for instance, and they ask me as clinician, so how does this work? And you really have to think along with the patient trajectory, the digital trace. So we need each other here. I have an example of how you could, for instance, optimize occurrence or influence that care organization. What we did in the Utrecht, my center, is that we made an organizational structure that all the patients visiting our cardiovascular departments, that can be from obstetrics to neurology, cardiology, etc. They all get a same set of cardiovascular risk factors measured, and we register this in a uniform place in the electronic health records. So this is why we know that for all our patients we have this information at the same place, and how this is not an indication, for instance, that the clinician thought I must measure this, but that we decided together that we think this information is important for our patients. And other, also maybe you know the common data model is another way of optimizing occurrence, is optimizing the standardization of how we track our data. So try not to register everything in free text, but also in structured fields, so we can actually extract it from the electronic health record. So let's assume we found ourselves a data source that we think the feature can occur in, and then we see whether the occurrence of a feature meets the expected completeness. I have an example here for you. As both an epidemiologist and somebody who's interested in gynecology and obstetrics, I tend to work on cardiovascular risk after preeclampsia, so disease during pregnancy where you have hypertension and proteinuria. And what we know is that these women have a 2 times higher risk of developing cardiovascular disease later in life. So what I thought is, let's see if also the cardiovascular risk factors are elevated before the age of manifest cardiovascular disease. Well, and it was. So then we think, okay, we need to screen these women earlier. And in 2016, a colleague of mine published a guideline in the Netherlands where we said, okay, we have to measure these women from age 55 onwards, while the general guideline says measure risk factors from age 65. So what I then was looking for is, do we really follow these recommendations? Do we measure these risk factors in these women? And in the Netherlands, cardiovascular risk management is a GP task, because they have the longitudinal care and they see mostly old families. So what we decided is that we would analyze what is the risk factor, the cardiovascular risk management in these women in the GP records. So we extracted data on this on over 300,000 women, and then first started to look into the prevalence of preeclampsia. I will talk you through this graph, because what you see is 5 boxes with age categories, and on the y-axis is the prevalence, and on the x-axis are the years, which were relevant to us because we were interested in the 2016 guideline change. And what you see is that the prevalence in, for instance, 25 to 39 years old, as the second box, is, well, between 0.75 and 1%. It's a bit similar in the 40 to 49 years, but then in 50 years and older, it crashes down, which is actually not possible. You expect the prevalence to go up in the fertile years and then stay stable in a dynamic cohort, which is this GP records. So what happened here is that we either have a registration problem, because mostly the 50 years and up women, these health records would have been on paper, and we had to migrate those to electronic health records. So maybe it's just not traceable. Or there is a communication problem. And I think the answer is both, because what we see in large cohort studies on preeclampsia is that prevalence is actually around 2 to 5% in the Netherlands. So this is up to 6 times lower. So these are issues why your occurrence does not meet the expected completeness, and you really have to do these quality steps before you start making nice mixed models, which was my plan initially, but I decided not to, because these patients I know had preeclampsia. These are unicorns. Then another example, what really helped me is to know whether it's a completeness problem or a care quality problem, because sometimes that information is not there, is also a sign is that there's substandard care. And what we did in the Utrecht cardiovascular cohort is measure all these risk profiles for all the patients. And what we then did is again look into GP electronic health records from these same patients, linking via a trusted third party. So we sent a few identifying information points on these patients to a third party who connected our data, got the identifying information out again, and sent the data to me. So I still have anonymized data. And what we then did is look, okay, we have these risk factors measured in these patients, and we expect, if we find that these risk factors are elevated, for instance, 2/3 of our patients had a dyslipidemia, so too high LDL bad cholesterol. And what you would expect that they would be measured in general practice again within at least 3 months to see how treatment works, or within 1 year, because it's a yearly follow-up thing. And what we then did, so I both look back in time to see what happened before and after. And I'll explain you the graph again, because in the middle you have the cohort I started with actually. And what I saw that for 52% of the patients, any of the cardiovascular risk factors was measured in the 13 months before the cardiovascular cohort. So before they were referred to a center. You could think, okay, maybe the GP assumed that this would be checked in hospital. Nonetheless, it's quite low. In patients, you would expect this yearly. And then if you look to the 12 months after the hospital check, we see that only 1/3 was checked upon, which is astonishing considering the high level of abnormal values we found. So this is actually not a completeness issue. This is a care quality issue. And this is the fun stuff, to really keep in mind what you're looking at. Is this a data issue, or is this actually an answer to one of the questions? How is cardiovascular risk management quality in our region? And well, I can tell you we have some work to do here. Another thing I think is important to take in mind is what I call process context. I want to illustrate this with an example on LDL trajectories in cardiovascular patients in our own center. And what I did is I looked into all the LDL measurements in our center for the last 15 years, and you can have different scenarios. Here on the x-axis it's time in months, and you see red and green dots, which is on target or off target measurements. So some patients only had one measurement and were then lost to follow-up. Then there were patients who were evaluated within 2 to 6 months. You could say this is a short-term evaluation for maybe a changed or a commenced treatment. And then you had patients with the follow-up within, well, somewhere around a year. I took quite a wide span there. You say, okay, this is the yearly follow-up evaluation. And then we had follow-up that was either too long to be related to the first measurement or too short to be evaluating a new treatment already. And what we did here is just evaluate how the trajectories went on and what are risk factors that are associated with staying off target in the next measurement again, because being off target is not per se the problem, but if it keeps like that, we're not doing our jobs correctly. So I'm giving you a part of the table, which is in whole published in the Journal of Medical Informatics. But what we saw, for instance, if we looked into the different statin, LDL medication types, is that this is the odds ratio. Above 1 is the higher odds of being off target. So above 1 is that. What we see is that patients that got a higher dose of the same type of medication have a higher odds of being off target. This is weird, right? So what we did not know is the timing of the prescription to the LDL measurement. And what could really be the case is that the LDL measurement was taken, that the clinician saw that measurement and thought, okay, I have to up the dose. So these are issues you need to really think of when analyzing these data. And not the conclusion of this paper was not that the statins don't work. It's that we need to see if we can track what happens, what's the chronicity of the timing of each feature for the LDL versus the statins. So process context, keep that in mind. And then the last step, so we established a data source we think our feature can occur in. We think it's complete, and then we need to know whether it's true. And I would say, first and foremost, try to find the digital trace closest to the event or to the feature. For instance, if you're interested in a certain CABG, coronary artery bypass graft, then go find the OR reports. Then most patients really had the CABG. If you don't have that kind of information, then I would say follow the money. So look into the billing procedures. We have the system in the Netherlands where we bill based on diagnose. The downside then sometimes is that you lose detail. For instance, pneumonia and pneumonia with sepsis are both in the one same money category. And what you could also do is use a reference standard you think has the good quality. And some of you who have seen me present in Brisbane might recognize this example. What we did is we mined the smoking status from patients in the Utrecht cardiovascular cohort from the electronic health record and compared it to what we registered when they visit us first, to see if we could maybe just get the information from the electronic health records, and also if we had missing data, if we could mine it somewhere else. And what we found is that actually from these 1,400 patients, we could really find the mind smoking status. But as highlighted in red, there is a lower positive predictive value. So In some patients, the mind status said that they were still a smoker, while in our cohort, they stated not to be a smoker anymore. Looking then into a non-dichotomized data is that most of those patients quit by the time. So if you compare to a reference standard to see if your feature is true, then really take in consideration time and clinical management, that you try to be as cross-sectional as you can be, as you want with the and also think whether this is really a problem. For our case, we use this data to make risk predictions, and you do not expect this risk to go away within a few months, because this was a time span of half a year. Yeah, time and clinical management, take it into account. So this was the first part of routine care data, and if you would only remember one thing, then please make sure your data is fit for purpose. Then the second step I'd like to take you to is the analysis and interpretation. Try to translate this data into actionable insights. And of course, this is something as statisticians you do in a daily basis, and I'm very thankful for your help for that. But I want to challenge you to take it a step further, because inherent to routine care data are some issues. And first of all, we have missing data. What we did in the cohort is that we programmed a cardiovascular risk management dashboard, and there it comes, boom, it's a bit big. What you see here is actually a current situation, a prediction, and a suggestions for therapy. And in the above section, you see medical history measurements, laboratory measurements. Then the dashboard generates a 10 years cardiovascular risk score dependent on history. This is for patients that had a cardiovascular event. But you can also say, well, I want freemium or I want another risk score. And then it generates the suggestions for therapy with the ability to click on and off these therapy suggestions to see what it does to the risk, to really make an informed decision-making process together with your patient. So what happened now is that blood pressure and LDL cholesterol was not measured, and then machine says no. What happened then is that you would think, oh, the clinician must measure that blood pressure or send the patient to the lab. No, they call me and they say, Katrien, your dashboard doesn't work. So what we then did here also, of course, for scientific purposes, is to see if we could impute this missing data real time for this one patient. And be aware, this is different than when you're in your scientific setting where you have an entire data set of patients with information you can feed to the imputation. This is one patient with only, well, the measurements you have here. So what we did is compare three methods: mean imputation, a method that's comparable to mice multiple chain imputations, and a joint model. And I will show that last one to you right now. So what we did is, if you look into the left side of the graphs, we had a training sample and we took all means and prevalences of dichotomous and covariance of all the predictors. Of course, you assume then that those are normally distributed. And taking this, we could then in individual patients construct normal distributions based on their individual measurements, and then draw imputations for instance, the missing measurement, in this case, pointed out cholesterol. This really worked well, and I think we have a coverage of the true value of 97% in this method, which is fairly easy if you want to fit it to your own population again. It's still under review, so I hope that I can share the paper with you soon. But this is, I think, a good example of how a practical problem, how statistics and mathematics can help solve the practical problem of routine care data. another issue intrinsic to routine care data is confounding by contraindication. And what you see below is a figure from a New England paper on propensity scores, which is the probability giving confounding variables or baseline variables that a patient would be selected for treatment A or B, in this case a PCI or a CABG. And this is a very elegant way of getting this natural phenomenon of confounding by indication out of your data and really looking at the effects of your treatment. And I would also really recommend this paper by my colleague Alicia Au, which they used a propensity score match analysis from the Swedish Heart Failure Registry to see the association between beta blocker use in mortality and morbidity in older patients. It really shows that sometimes confounding by contraindication, or by indication in this case, can cloud your results, and that you should use these nice statistical methods to counter it. But we must not forget it's not all pitfalls, it's also potential. And what now is happening, of course, is deep learning and machine learning methods that can really handle the multidimensionality of routine care data, of images even, and that we can look for things we are not aware is there. But I have one little example, and I did not find the true paper yet, but I did find a page where it is being discussed. And that is that what was done in a radiology deep learning study is that they wanted to associate chest X-ray features to death, to mortality. So they took, this is a chest X-ray. For those who are not used to reading these, you see the ribs, it's the white, and in the middle you see the heart and the lungs. The lungs are a bit more black, and they should be a bit more black. There's a pneumonia up there somewhere, I think. And they were really able to predict death well based on these these chest X-rays. And then the researchers were going more in depth into which part of the X-rays was actually most informative. And what was then highlighted is that there were two more whitish things in the upper corner, so supine and portable, that were most informative. Usually, chest X-rays are made in the radiology department in a stand-up position. If a patient is too sick to come to the radiology, then a portable machine will come to them. If they are too sick to stand up, then a chest X-ray is made in a supine position, so lying down. So actually the information that was most predictive for death in this case was not the features of the lungs or the heart of this picture, but that the patient was too sick to come to the radiology ward and stand up. So this is a good example of how there is more information in routine care data, but you have to be aware what is in there. So again, talk to your clinicians. And lastly, and this is not my expertise, but I do have a very nice quote of one of my colleagues on this, is that if you make models, well, prediction models are like models on the catwalk. They're overly fit and only a limited representation of the truth. I probably do not have to tell you this as statisticians, that you need to validate and think of recalibration models if you're reusing it. But I do think this is something we need to focus on together for the future, because if we use these risk models in dashboards such I just showed you, we do need to think of what is the quality life cycle of such models. When do we need to reevaluate this? And in medical utensils such as catheters or injection needles, we do have a post-marketing surveillance, whether the thing still works, still does what we say it does. But in software, in models, this is not that common yet. So I'm curious if we can start a discussion on that later, how you would think we should do this. So the end of the second part is what I want to give you, use the analytics to translate this data into actionable insights and really challenge yourself to solve these issues and also exploit the potential. Then lastly, the actionable insights, and this is where the patients really experiences what we do with the data and how we can help it. And I must say one thing, please help us clinicians, because if you do a model on a day-to-day basis, it's very logical, but there's hundreds of them and there's hundreds of measurements we need to keep in mind, and there's a actual person in front of us who also has certain wishes. So these kinds of dashboards really help to simplify the calculations and help us focus on what is important to the patient, that is discussing what they want and how medicine, how statistics can influence, well, their life. So really try to make the next step to bring the data into our consulting room. And it also goes the other way around, because what colleagues of mine did is they did an analysis on how much of the electronic of their trial data from a large Delodoco-2 trial on colchicine for patients with an acute MI in their history, how much of these data could also be extracted from their electronic health record. Some of you might know, if you do a trial, you need to select eligible patients, you need to invite them, they need to come, they have a informed consent, etc., etc. So it will take you about, well, in this trial, it took about 1 hour and 20 minutes per patient to get all the data. If they used an electronic health record text mining tool, they could mine almost 85% of all data in about 1 minute. So as clinicians or as scientists, ask your clinicians to see what information is already there, and if you can just restrict yourself in the trial to collect the data that is not already being collected. And in this trial, it helped save about 1 hour and 5 minutes per patient. And if you have a 3,000 patient trial, this is a lot of time, and will save you in the end the costs again without getting less quality data, of course. So the third part, I want to close down by again emphasizing that you need to use those technologies to integrate the care and science in practice and vice versa, so we can keep helping each other. And as a last part, I want to highlight to you that learning healthcare system and the work we all do is, of course, for in the end for people. And what I want to give to you is this graph, which for me is the data meets narrative situation, because you have a patient and a healthcare professional, and what I would really like to see in the future is that data is becoming a third partner in the consulting room, informing both patients and healthcare professionals, and really having a true role in that room by supporting, in the end, the traditional relation between patient and care professional. So this is what I would conclude with, and I would really say just go as you step by step, go as I just showed you. We just tried every step, and in the end it's learning by caring. So thanks a lot. Of course, I have a lot of collaborators which I all listed, and most of all the patients I used data from. The cohort was financed by our center and by the Dutch Health Organization for Health Research. And of course, I'm happy to answer your questions.
Thank you so much, Katrien. That was fantastic. I think it's really great to get an overview of the use of this data from someone that's looking at it from both a statistical and epidemiological perspective, as well as a clinician thinking about it in that pathway. And you're absolutely right. I think it needs us to communicate more effectively to make sure we understand what data are out there. So I'd like to open up for questions now. Has anyone got any questions they'd like to ask Katrien? Either feel free to unmute your mic if you would like, but it might be easier to type the message into the chat box. So if anyone has any questions they'd like to ask, please go ahead. While you're doing that, I guess to begin, Katrien, I've got a couple of questions. One of the challenges I guess we've been facing a lot using administrative data in Australia is just a lot of the pre-processing work that has to be done. I know you were talking about some of the work in standardizations. Now we are obviously using a lot of text fields, and it's very, very difficult, and it's hard to ensure that we're making sure we've got good quality. And we're comparing like with like, I guess, because different, say in primary care, different GPs might be using different things. Have you got any comments to make about the pre-processing of data that you've had to use in your own projects, or how you've managed to use some quality assurance?
Yes, that's I think 90% of my PhD was pre-processing. So yeah. Yes, this takes a lot of time, and I think if you want hands-on tips, again, I would start with the one who is collecting the data, so who makes a digital trace, whether it's a nurse, whether it's a clinician. So you understand how it's generated, then you can really start with valuing the quality of the data. If you have free text, then yeah, you quickly end up in methods such as text mining, and you can use them from very difficult machine learning based text mining. But the one we used in the smoking is actually a regular expression, so just looking for keywords and around. It's not too complex. The downside there is that you do counter that it's sometimes a bit text specific, so that different clinicians or different departments use different abbreviations, for example. So you need to see whether you need to really specify it or calibrate it to that data source, if you like, or that you could reuse it again. And I think that is also, if I can be a bit of a dreamer, what I want us statistician clinicians to work together is that we could work towards a setting where, wow, it's a cite while you write situation. So you type in, for instance, blood pressure is high, and that the electronic health record asks me, do you want to register diagnosis hypertension? So that in the front side, it is free text. And as a clinician, I really like my free text, because that is where I nuance my clinical reasoning and patient's wishes. And I think that's what's the humane part of medicine. But as a scientist, I really want those structured yes or no's. So yeah, I would work towards that, and we chose to go a middle way, so collect a standard set for our patients as well, to there start with high quality data, so we have a basis. But yeah, that's also has organizational challenges, and of course money wise.
Yeah,
so,
absolutely.
It's not a too short answer, I'm sorry, but
No, I didn't expect it would be. I have to say it's something that I find very challenging. So I'm just going to go over to the messages. I think there's a couple of questions. I think Jessica, have you got a question to ask?
Yes, I do. I'll unmute and reveal myself to ask this. Thank you so much for that great talk. It seems that a lot of what you were saying kind of it comes down to statisticians and the people who are running these things having a clear understanding of the causal structure of the relationships, so how everything is related to each other in these databases. And I was wondering if you wanted to comment at all on this sort of causal understanding, because in my view, that's where the relationship between statisticians and clinicians, where the great strength is. The clinicians, you guys have all of this subject matter knowledge, which we can then use to understand what is actually going on in the background to help you answer your questions. So I guess this is a pretty sort of vague question, but what are your thoughts on that? Thank you.
Yeah, I think you're spot on there. That's actually exactly where the strength of both things is, and I think maybe data managers are in the middle, because they are the ones in the Netherlands at least who are in charge of good quality and data to really manage the databases. I think it's the strength of the collaboration. What sometimes is forgotten is that what I see around me a lot now is that there's medical bioinformaticians or biostatisticians that just get a large data set because they are able to do these machine learning, deep learning, big data models, ding, 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 for the bingo. But they really don't understand how it happens. And then you get these weird results of what did I just saw, that women were recommended, overweight women were recommended to start smoking because they had lower risk for big babies and complications during labor. Well, this is a big problem. So yeah, I totally agree that the power of collaboration is using everybody's expertise.
Yeah, great. I've got another question here from Xiaoyi Liu, who has said, thanks, in current data mining, would the data features usually represent data?
Ooh, I would maybe ask Xiaoyi Liu to elaborate on that question. Could you maybe?
Yeah, do you want to turn your mic on and clarify the question if you're still online? Are you still there?
I think now we can hear you.
No, I think you're still unmuted. Okay, well, maybe that's something we can cover in the breakout session. So the only other comment I could see in the comment box was just from Alice Richardson saying that she was thanking you for your stimulating talk and talking about the importance of standardizing data, and that's something that Florence Nightingale was calling for in her work, and we're still talking about it today. So yeah, it's certainly an important issue.